manage reproductive and maternal health services and programming from the Ministries of Health at sub-national level. So these are really the engine room, the people on the ground making things work. So we're going to hear their experiences, how they want to take some of the issues forward. So that's the first session. And to help us manage this session will be Dr. Helen Allott, who is seated in front. Thank you so much, Helen. We're also going to, and we'll be expecting the following people to take part in this. So probably, I'm not sure we have enough chairs up here, but we'll have to improvise somehow. We have Dr. Slim from Ministry of Health Zanzibar, probably not here yet. We have the Regional Medical Officer, Dodoma, Dr. Thomas, to join us on the high table. Fatima Ibrahim Isa, Samson Meli from Vihiga, and Dr. Babatunde from Oyo State Ministry of Health, and Nafisa from Kaduna State, Nigeria. So these are the colleagues who will take part in the first session. The second panel, which we will have this morning, will be focused on research capacity strengthening. And here we will have Vice Chancellor joining us, together with Dr. Salma, Dr. Uzo, and the two PhD students who are available for that conversation. And that session will be chaired by Dr. Bashir. If he's not here, then I think Rai can manage that session. Then our last panel for the day, which will take place after lunch, will be focused at discussing the pathway to change and impact, but discussing with people at a higher level. So those ones who sit at the Central Ministry of Health, Dr. Makwani has had to leave, but I know Dr. Bashir and Dr. Henry Jones are here. So we'll make the best of those who are still available to tap from their wealth of knowledge and experience to look at how we can move things forward. So that is the plan. So without further ado, I will hand over the microphone to...
She's carrying a garden rake, and she's carrying the baby. And this is the life of many African ladies, isn't it? It's very hard work. So we owe it to these women to do the very best we can for them in terms of their health and safety and the quality of their care. So there you are. I'm wearing the advocacy instead of running it. And thinking about what we've learned from implementing the program, and think about what challenges we encountered in our different settings in particular, and how you overcame those challenges. And then what, if you were starting all over again, was there anything that you might do a little bit differently because of the lessons that you've learned? So I'm just going to pass the microphone along, and if everybody would like to address those questions from their perspective, the challenges you encountered, how you overcame them, or if you couldn't, what lessons you learned in the process, and what might you do to improve if you were starting out again. So can I just pass it to you? Stop.
Good morning. Let me appreciate LSTM for this opportunity. It has been a very wonderful one, especially having them in the state. They have turned a lot of things around in terms of service delivery, in terms of health workers, capacity building, attitudinal changes, and what have you. Well, I think, let me say this very quickly. they came into the state at a point in time when we were struggling with the issue of how to have effective service delivery in terms of having a better FR. And thank God they have intervened where it was necessary. And how do I mean? In terms of capacity building, over times we've not had it so nice because the resources were not there. Resources I mean in terms of 4 M's: manpower, materials, money, and minutes, which is time. So those resources were not there. But when it came, they actually filled those gaps for us. Though we were not yet there, but at least substantially, they have done something worthwhile. Now, in the process of implementation, there were a lot of challenges that actually were on ground. Take, for instance, like I said, the issue of manpower. And let me say this before I even go further. When we're talking about sustainability, scaling up, ownership, it has to do with political commitment and political will. And that was expressly given by the governor of the state through the commitment of the Honorable Commissioner. And because of issue of manpower that we have, not quite long, His Excellency approved engagement of healthcare workers, about 5,000 of them, into the primary healthcare facilities. And we believe with this, the issue of manpower, though it might not be probably resolved all the problems, but substantially we know it's going to go a long way to ensure that in terms of service delivery, in terms of manpower, I think that particular gap will be filled up. Then again, the issue of equipment and other materials, those things were also very, very difficult for us before LSTM came on board. But they filled the gap also for us, and we have felt the impact in terms of service delivery and other services that they render. Then outreach sessions that were not either conducted, they came in and outreach sessions were conducted, and that has actually improved the coverage. I was saying the other time that when we're talking about coverage, they don't need to forget the fact that demand creation, very, very important. And how do we do that? They were there filling the gaps in terms of community mobilization, sensitization, and engagement. So they let the community members to see that the reason why they have to seek, interventions in their facility, not saying at home, delivering at home, but they let them to see the reason why they have to come to their facilities. But to ensure that this process goes on very effectively and uninterruptedly, I think there was a program on ground, but we actually, reactivated that, and that is DPA. You call it Director of Public Health Coordination Meeting for integration of HIV, TB, and malaria. So that meeting, I usually, chair the meeting, and we normally have a lot of partners that have something to do with HIV, TB, and malaria there. We have head of agencies like SACA, State Action Committee on AIDS, representative from Primary Care Board, then we have all other people there. But because of this program, we have ensured that it must be sustained. And what we did is that coordination meeting must be replicated at the level of primary care. So, and what we normally do there is that we ask those at the point of delivery to tell us the challenges, issues that they have been confronting with, and we resolve it at that point in time. So, because of this program, we have now invited them to be supplying us with data, integrated data, of HIV, AIDS, and malaria, so that we look at them. So, if there are issues, in terms of personnel, in terms of materials, in terms of even funding, they will be able to, look at it and provide solutions to them. Then the challenges, I've talked about it. Then the lesson learned is that I think people are ready with enthusiasm that, if knowledge is being brought to them, they are ready to accept it, so it will develop their capacity and they have another brand new skill set to ensure that we have effective service delivery. Then apart from that, they are operating in 60 facilities compared to about 800 primary care facilities in Oyo State. So what we're able to get from it is that if that is scaled up, then it's going to turn around the service delivery in terms of coverage and improve maternal and child health outcome. So those are the lessons learned there. And then we also gather that, it helps us to have what I can, just like a one-stop shop or one-stop service, that when you come around, they receive all the services they need at a visit, unlike what it is. Okay, all right, okay. So by and large, I think it has brought a kind of, it has given us a kind of opportunity that we actually leverage on as a state. Thank you.
Thank you very much for that very comprehensive answer. Just in the interest of everybody being able to speak, I think we're going to have 3 minutes each for the answer to this question. So, sorry. So let's just pass it along, but I will keep an eye on the clock. Well, you've got another microphone now, that's great. Thank you.
Assalamu alaikum, good morning. I'm Fatuma Isa from Kenya, Garissa County. We were given only 3 minutes. He's privileged because he took more than 3 minutes. But that is the beauty of becoming the first person. So to start with, we are very grateful to LSTM. LSTM, actually, Liverpool School of Tropical Medicine, are very dear to us because we started our collaboration back in 2014. And I really want to testify that I was among the first people who were trained on, emergency maternal obstetric care in Garissa. And being now a trainer of trainees, I was able to actually mentor a lot of people in Garissa. And actually it boosted my, my confidence to, attend to these maternal emergency cases. The other thing I want to actually highlight here is that LSTM, when they came on board, capacity building of healthcare workers in our county, that is Garissa County in Kenya, was actually very, very, very low. And having come up with quality improvements in terms of ANC, PNC, and also the standard-based audit cycles, it has really improved our service uptake, including the antenatal coverage, and also hopefully the maternal deaths was not captured in the 2022 DHIS, but hopefully it will be done. And I believe that we have really reduced from being the leading in the country, because Garissa County is actually the leading county in maternal mortality in Kenya. That is around 641 per 100,000 live births, which is very sad. And that one is actually attributed to so many things, like, for example, the geographical distribution, the climate change, including the drought issues, the floodings. The clients are not able to come to the facility. So we were able to actually mentor a lot of staffs at the far-flung areas, and they are able to, like, for example, the standard-based audit, they are able to take up, a standard, they measure that standard, but at some point, the staffs, were not able to complete the standard. Why? Because there was limited equipment. There were no equipment. Equipment was an issue. So we are, again, very grateful to LSTM because they came on board for us to achieve that standard and provided us with the basic equipment. That is about capacity building and issue of equipment. The other thing is about, maybe if I talk about challenges, my 3 minutes is about elapsing. Challenges, the issue of challenges was about when it came to the blended learning in ANC and PNC, the issue was about network coverage. Network coverage was an issue because some of the areas, I had even one of our staff posting a photo. I had that photo that he was on top of a tree to look for a network, so that he can at least get that, the Zoom meeting. Yeah, you can get that information. But by and large, the blended learning actually it is cost effective, and it is the way to go for us, because that is what we think that actually it can help and reach a lot of people during the self-directed learning. For us to sustain this program, we are always very poor in sustaining programs, but hopefully we will do very well this one, because we are going to dwell on, or maybe leverage on the support supervisions, on mentorships at the county level. And I'm planning, actually, I have to do an advocacy package for reproductive maternal newborn health for the ending preventable maternal mortality, and also in an action plan, where I have to sit with all the top leadership, including the CDCs, that is the ministers, and also the chief officers, and we were able to actually point out the risk of having, of being actually number one in every time, in maternal mortality in the country. And we got that buy-in from them, and they were very supportive. Hopefully, our budget line will be approved in the work plan and also in the strategic development, hopefully.
Thank you so much.
Yeah, thank you.
Thank you, Madam Chair. I'm Thomas, the Regional Medical Officer for Dodoma. It is unfortunate that the Dodoma region is the only region in the country which has been implementing this project. We are very grateful for the project support. Actually, this project is very relevant to us, as it is anchored within the national policy as far as the public regulations, safety regulations are concerned. It is the responsibility of the employer to ensure that there is continued professional development. And when you go to our national strategic plan 2021-2026, it is straight that the Minister of Work will ensure that to build the capacity of staff to ensure that all staff are actually updated to the current changes in the health sector and worldwide. Another thing is about our professional requirements, particularly in our professional councils. Every year, the professionals are required to update their registration. One of the requirements is to have CPDs. So this training, the training our staff got, has been pivotal in our retention in our professional councils. So we are very, very, very grateful that we have seen the changes as far as the maternal mortality is concerned in our region. Recently, we are getting downward the trend from particularly in those facilities where benefited from this training. As far as the blended method is concerned, still really the way to go, because it saves money, but we had a number of challenges. It has already been mentioned about the issue of network, but we have an issue of competing priorities at the facility level, particularly in health facilities where the human resources are minimal. Sometimes it was a bit challenge when we are talking about Zoom, attending the training, while you are required to deliver the services. So it's among the reasons that maybe in the coming phase of this project, we need to have allocation of staff in consideration of this staff training. And we came to learn that also, in order to maximize the achievement, we need to have motivation in between. For instance, in our case, some of the staff were motivated to attend because they were requiring CPD points. Nurses, they need CPD point for their professional requirement. Medical doctors also, they had similar requirements. So it was a motivation. As far as the sustainability is concerned, we think that we have enough opportunity to enable the environment. We have the similar or less project which address maternity and the child health. We think we are able to integrate this methodology with the other existing malaria programs, with the other existing TB programs, and currently, from the lesson learned from this project, we have integrated TB screening in all OPD cases. Any patient visiting the health facilities in our tracking the patient, we have TB screening is one of the requirements in our electronic system. We have got the government of Tanzania health operation management system. So this has been integrated. Whenever you see the patient, TB screening is a requirement. So we are very, very grateful for you, Dom. We are very grateful for you, Liver School of Tropical Medicine. We are very grateful for this considerable support.
Thank you. I feel very grateful for this introduction. Actually, you preempted the next question, which was more about scale-up and sustainability, but thank you very much. Let me hear from the next panelist. So the question is about your challenges, the lessons you learned, and whether you do anything differently.
Thank you so much.
Thank you.
So thank you so much. My name is Nefisa Musa Isa, and I'm coming from Karibu Zantime, Nigeria. I would like to start by appreciating LSTM for selecting Karibu State to benefit from this intervention. So this particular intervention was implemented in Karibu State across 6 facilities, and we were able to have a training of more than 800 care workers. And also, following this training, we have significant impact. We have seen significant impact in the uptake of ANC and ANC services across the state. So some of the lessons that were clearly outlined during the intervention number one is integration of services, where we have clearly seen integration of services that has really come up with great impact in the state, and that has made the state to adopt that to be able to scale up integration of services across the facilities, as well as doing outreach and doing mobile outreach across the state. And the second lesson we have also seen is the capacity of building of healthcare workers that has really, and the availability of equipment that has really given the healthcare workers confident in providing services across the MNCH continuum. And we have also seen a lesson from availability and the use of IEC materials, as well as availability of partograph and use of partograph during labor and delivery, that has really reduced the pregnancy complication, and it has also shown early referrals to facilities. And another lesson that we have seen there is community intervention, where we have seen that community involvement is very key in all programs, so that the community will take ownership at the end of the program. So some of the challenges we have recorded during the implementation, just as it was mentioned during our presentation yesterday, is irrational transfer of healthcare workers that really distorted some of the programs in some facilities that were already selected. And we also have insecurity across the state, where we have insecurity in some part of the state that is really distorting this part, some of the intervention in the state. And for sustainability, I think the most important part in sustainability is for the government to be able to take ownership, where I know in Kaduna State, the government has already taken ownership, whereas at now we're able to train up to 2,000 healthcare workers on quality of care, and we have aligned and also integrate quality of care MPDSR at the state level, and we're also able to form quality of care teams across all our 23 local government areas, and we also form quality of care teams across 205 facilities and wards across the state. And with that, we are also able to form, have funding to be able to scale up mentorship across all the facilities. Now the state has taken the ownership to be having quarterly mentoring of healthcare workers across the state for us to be able to sustain the lessons, the learnings from what has been done.
Thank you so much. Okay.
So I will round up by appreciating LSTM for opening our eyes and Kaduna State for us to be able to see the clear road, for us to see the impact, and also to be able to sustain those interventions so that we can move forward towards the adoption of maternal and child mortality in Kaduna State. Thank you so much.
Thank you.
Good morning, everyone. My name is Veronica Musega from Kenya, Vihiga County, and I really want to appreciate LSTF for starting us off on matters quality improvement, and to say that was an eye-opener for Vihiga, following the QI trainings and the NCPNC, malaria, HIV, TB. We really had made improvements in the county. Up to national level, where we even have presented the various abstracts, where we have done very well in increasing the uptake of ANC mothers, and also post-pregnancy family planning in most of our facilities, and that has been a very plus for us. The challenges that we experienced in Vihiga after the trainings, maybe when we had our providers trained in NCPNC and QI, we had the challenges when the management were not, maybe some resistance from the managers because they were not on board. So we had to strongly bring them on board to be able to understand that why we must talk quality. And then we also had issues of equipment shortage because some of the providers were very ready to implement. However, they did not have equipment like the HemoQ machines, the blood pressure machines, the point of care ultrasounds, but that was worked on thoroughly. As we talk now, most of the facilities are able to access point of care ultrasound. They are able to do the HB testing every trimester. We also had issues of staff shortage and also the deployment of staff, just like the other people. But we really talked, and last week we just had staff being employed to really, especially that replacing those that went out for attrition, maybe retirement, or maybe those that went out for greener pastures. Then again, we had matters of maybe stockholder engagement, especially at community level. We did not have that strong advocacy, just like what we did this morning. The community were not aware that they really needed to initiate ANC as early as 12 weeks, so we really need to do, we had challenges there, but we're still working on it. Then we also had low uptake of some of the facilities initiating the QI projects, so a lot of follow-up had to be done in order for us to really have everyone on board. The key lessons learned that we had in Vihiga, we realized that continuous follow-up of our providers who have been trained was very pivotal in helping us initiate QI projects in most of the facilities that the providers that had undergone face-to-face and even the blended learning. That was very key in helping us improve the uptake of ANC, PNC, and also provision of quality improvement. Then we also learned that availability of essential equipment, commodities, and supplies in ANC, PNC is actually a key factor in helping us improve the quality of care for our ANC mothers. We also learned that enhanced documentation and data utilization is very pivotal for ANC and PNC, and community mobilization and sensitization, again, is very, very important. Some of the strategies that we have really used, we're going to use to help us sustain the newly being created SHA Shield. You hear about it in Kenya. We expect that every mother who delivers in our facilities will earn that facility approximately 10,000 Kenyan shillings. That we hope that our facility charges are going to help us utilize it to sustain more QI projects and also mobilization of clients at community level, including the enriches, the outreaches, the intergenerational dialogue days, so that we are able to improve. Then the primary care networks that are being created again with the new Shisha. Again, we are going to take advantage of it because every dispensary is a PCN, so we're going to have that in place. Then at community level, we also have the electronic health information system where every CHP captures information of pregnant women, postnatal women, the children, and that is really going to help us in enabling them to come to the hospital for ANC early enough. Then, Then just as I finish again, we hope that we also have started the weekly virtual meetings and also the monthly meetings for the sub-county and county. And we, next week, are planning that we also coming strongly with the Vihiga action plan in ending preventable maternal deaths and also early newborn action plan. Thank you.
I think the whole world needs a Veronica.
On PNC integration, they became motivated and confident in handling plans, especially when it came to high workload. We've seen even facilities where there is one staff, they are able to meet some of the standards. That means that they became motivated. The second one is that healthcare workers are now providing services as a right to the client and not just as a routine procedure. Blended training, for blended training, I realized that when staff are now called for face-to-face training, they already know, they have an idea of what to expect. And that helps build their confidence for them to even read further before going to the face-to-face. The standard-based audits. The standard-based audits opened our eyes for the importance of generating quality data. And this especially worked for the facility managers, so that they were now using quality data in decision making, especially in appropriate staff placement. I also realized that blended training does not interfere with service delivery, because staff are there. They can even do the virtual training while on duty, and therefore there's minimal movement of staff out of the station. Finally, the presence of a QI mentor in a facility. I realized that in some of the facilities, the QI mentor works like a standards standard policing officer. Every time there is an issue about the standards, this is the person they refer to, they call this person even when they are off duty. Now, coming to challenges, there is, I don't know if they have mentioned, there is a high staff turnover, and this is because of out-migration of staff outside our country. The biggest culprit being the National Health Service of the United Kingdom, who are poaching our staff. And I'm surprised they poach the most experienced and well-trained. So we keep, needing resources to keep training and training. Probably we need to change our national policy. I don't know if Dr. Bashir is here. We need to look at a bilateral labor agreement. If Dr. Bashir is here, we need a bilateral labor agreement with the UK, the US, and Australia. These are the victims that pick our staff the most trained, so that if we don't have a bilateral agreement with you, need to start paying us royalties for the staff we have trained. There was issues of internet accessibility. I think the internet is not an issue in Kenya. The issue was bundles, especially for the virtual training. Maybe in future we need to consider that. Attaining some of the standards requires a lot of resources, especially in the health systems adjustments. That's also another challenge. Maybe we need to introduce in the same curriculum a resource mobilization topic, so that staff can understand how to mobilize resources. The other challenge was health system challenges, the usual ones, shortages, ignorance, especially of the health managers on QA, and insufficient supplies, outdated aging technologies, especially the equipment. That was another challenge. Another challenge was perceived low CPD points being awarded by WCEA. Health workers were complaining that you sit in a course for 2.5 hours, they award you 2 or 1 point CPD. And that one, I think LSTM now can advocate for us. They need to increase the CPD points as a motivator. And probably also LSTM can work with other CPD providers like the Challenge Initiative and Daktari Online, especially for doctors. For purposes of sustainability, we need to include this proven evidence, what has worked, we need to work in the RAMCA roadmap.
Can I just pause you there, because we're going to come on to sustainability next.
Yes?
I said, can I pause you, because we're coming next on to sustainability. But you've outlined very articulately several of the challenges. So I just want to summarise, if you don't have a seat for a minute, I want to just summarise what I think we've heard about some of the challenges that you've all encountered. So we've heard about network challenges and the provision of bundles, so airtime for staff can be a challenge. We've certainly heard about equipment and how LSTM has been able to help with that through this programme, but of course no equipment lasts forever, so there needs to be replacement budgets. We've heard in Garissa about the climate change impact, and that's beyond our control, but I think it's an important issue for staff in remote rural facilities when there are floods and so on. We've thought about the motivation of staff and what you can do to motivate staff with CPD points, and I think that's a very good point you've raised, that maybe the CPD points have not been enough in terms of the hours expended by the staff on the self-directed learning, and I think that's quite an easy thing to fix. Another thing we've talked about is staff levels, which is a perpetual challenge, and having the time to do the sessions, whether it's the Zoom sessions, which are contemporaneous, or the self-directed, which is individual. And obviously it's a benefit to spend less time away from the facility on the face-to-face, which is now shorter, but still there are challenges with staff levels and the conflict between provision of care and learning, and also the issues of staff rotation, which is for you guys to fix, I think. And I think there's many reasons why staff are rotated. Sometimes it may be their choice, sometimes it may be management not always recognising the expertise of the staff with the experience in maternity. We heard about civil insecurity in a couple of our locations, and again, that's beyond us to fix, sadly. But other points you've raised about how you overcame the challenges by creating a sense of ownership, and the mentorship in particular, I think are really important, and the idea of getting the management on board. I certainly take on board your points about staff moving internationally. And that's a very difficult issue. On the one hand, human rights dictate that human beings should have free movement between countries. On the other hand, it depletes people of their trade staff. And I completely agree with you that the United Kingdom should not be poaching your staff. I think it's reprehensible. We did have an ethical recruitment policy, and it seems to have gone by the board a bit in recent years, and I think it's very wrong that that's happened, but I'm not equipped to fix it, really. But you're very right. But it's not the only reason for poor staffing levels, because there are, I know in Kenya there have been quite a number of nurses who've been unemployed. So it's not just international migration, I don't think. But anyway, that's for another day. So we've heard about some of your challenges and some of the ways that you've overcome them, and I think that's very, very beneficial for us to take those lessons to heart. But let's move on now to scale up and sustainability. We've got another 50 minutes of this session. So, first of all, the question is, do you want to sustain this programme? I guess you do, because from what you've been saying. But then how do we go about it? Some of the answers we've heard about to do with mentorship. I would also challenge you to think about, could you do the training differently? Does it have to be one big course? Or can we do it in what we call bite sizes? So with your CPD, you do one little bit one week, another bit the next week, and so on. But you must have your own ideas about how to scale it up and how to make it sustainable. Clearly, we've touched on a tiny fraction of your health facilities in your countries and in your counties even, and there are far more. So I'm very keen then to hear about your ideas about scale up and sustainability. So maybe we can come back down the line this time. And again, 3 minutes.
I will start this time.
I'll stop you after 3 minutes.
So for us to sustain this program, the findings that have been shown to work, they have to find themselves into national policy. And to find themselves into national policy, we need to advocate so that this kind of evidence that we've identified to work can be included in national documents, the National Productive Health Policy and the National Roadmap for RAMCA. This means that once that is done and the activities are costed, then each of the facilities within our jurisdiction can implement, because it will now become mandatory. The other thing that we need to do is to advocate for review of our curriculum, both in-service and pre-service, and LSTM can help us do that. The other issue that we probably might have missed when we did the LSTM did the entry meetings was to sensitize the mid-level managers. We need to sensitize the mid-level managers so that they have their buy-in, so that these proven interventions can be included in our strategic plans and annual work plans. To sustain also, we don't need to stop here, and that means that we need to continue future operational plans, research, so that we need to link now quality improvement with the negative health indicators of, for example, maternal perinatal deaths, mother-to-child transmission of HIV, microbial resistance. These ones can easily be picked up by policy makers if they work, because this is the target of each of our countries. Finally, we need to invest in tools of the fourth industrial revolution. And LSTM should be able to lead us in this. We need to look at our health management information systems and inbuilt artificial intelligence and machine learning programs, so that this health management information system should be able to pick up quality issues in the data that we generate from time to time. This way, the health managers and policymakers will be able to push for the implementation of quality improvement interventions. Thank you very much.
We already have one sub-county having a skills laboratory. We're in our main hospital, and we have been doing mentorship in that skills labs. We bring in people so that they are trained on certain skills like newborn resuscitation, like on testing of using the HemoQ. So we bring up staff from maybe a particular facility and we orient them, and we hope to also scale up in the other 4 sub-counties. Then on matters staff shortage, I think we are also working on it. As I told you, Vihiga government is already doing some deployment of staff that went to the UK as we had stated, and also maybe retired, because we already have that salary of those that have left continuing to be brought to the facility. So just transferring the salary to the other new staff that is coming in. Then again, we hope to have an action plan, apart from our annual work plan that we always do per year, and we've been factoring in on quality improvement and also budgeting on the same, including maternal perinatal death review and response. We also want to come up with an EPMM, in-app action plan for Vihiga. So we want to look at the national one and see whether we can also have one for Vihiga or we can adopt the national one. Then, as I stated earlier, on matters primary care networks and social health authority and social health insurance fund, we're hoping that the national government, as it implements, we will have our facilities being able to receive funds, including our dispensaries, which they should be able to work on it strongly to empower our CHPs to go house to house, looking for pregnant women and initiating ANC early, and also have our facilities being able to do the tests like the laboratory tests, including the ultrasound. As we talk now, we already are carrying out special referral of ultrasonographers. We get them from the main hospital and take them to a dispensary during a maternity open day, and they are able to do ultrasound for the mothers within that catchment area. So we don't refer mothers, but we refer the specialists. Then again, we've started virtual meetings, just the way the blended learning was. So instead of having people brought together here, we do data review virtual meetings, including being able to monitor the quality improvement projects that we are carrying out in various facilities, so that they're able to present up to what stage they are, and maybe be able to get maybe recommendations and maybe any challenges they're experiencing. We're able to support them appropriately. I think we also hope that soon we will also be able to have our health data digitalized, especially on matters monitoring mothers in labor using a pantograph. And with that, we hope that our providers will be very vigilant, especially when monitoring on digital platform, and they will not miss out on any action, especially when they're using a pantograph. I think that's what I have. Thank you.
So thank you so much. In regard to sustainability of this intervention in Karibu State, as I earlier mentioned, that it's all about taking the ownership, and Karibu State has taken the ownership of sustaining it based on the national quality of care guideline in Nigeria. So based on the national guideline of quality of care in Nigeria, we're able to form the quality of care team in Kaduna State, and we also form that at the lower level, that is across the local governments, and we also form across 255 wards and facilities. And in regard to training, as I earlier mentioned, that as at now, based on the national guideline, we're able to train up to 2,000 healthcare workers on quality of care. And we are now having quarterly mentoring and coaching of healthcare workers on quality of care across the state. This is happening quarterly. And also, we are having a study now in one local government to be able to see how we can be able to align quality improvement coaching, so that at the end of the study, we will look at the findings and see how we'll be able to scale up the impact of it across the local governments of Kaduna State. And we are also looking at strengthening the community structure, where we have seen that the community structure is very key in the implementation of quality of care, where we are bringing all the community structure on board, the World Community Development Committee, as well as community volunteers that are constantly creating demand in the facility, in the community, and also making referrals in the facility. And in the facility, after Kaduna State has now adopted the integrated service delivery system, whereby when a woman comes to the facility, a reproductive age woman comes to the facility to access services, we ensure that before she leaves the facility, she also accesses other services across the facility that she really needs for herself as well as for her child. And also, we also have a system whereby we go out for outreach to facilities where they are within 2 kilometers, above 2 kilometers to the facility. So we take outreach there, where we also provide those kind of services in an integrated manner. And for facility for communities that are above 5 kilometers, we usually take mobile outreach, where in the mobile we have about 5 to 6 to 8 mobile trucks that are equipped with equipment that can be able to provide services in communities that are above 5 kilometers. In the truck, we also have gene expert machine that also we tested for TB across those facilities that are above 5 kilometers within the facility. So those are such kind of ownership that the state has already taken in regard to scaling up this intervention across Kaduna State. Thank you.
We're hearing some really lovely, innovative solutions there. Thank you. Let's just move along the line. Yeah.
Yes, for the case of Tanzania, particularly in the Dodoma region, we see a number of opportunities for sustaining this gain which have been attained from this project. Currently, as far as the training concern or capacity building concern, we feel we already have the TOT already in our region. We have the University of Udom, which we does always. We have started the discussion with them on how to continue the supervision in these 28 facilities which have been capacitated so far, to incorporate them with our routine supervision as a government, the government part. But on top of that, we just discussing with them to see how we can scale up even from the current 20 facilities.
The strengthening in-service, pre-service program to this second section, where we just want to reflect on the approaches to research and project management capacity strengthening. And would agree with me that the best people to begin these reflections for us would be our PhD students, whose work we have had a look at yesterday. Excellent pieces of work going on with their supervisors, and of course the Vice Chancellor, the Deputy Vice Chancellor from State University of Zanzibar. So we're going to start straight away, and yeah, please, Dr. Kasabula, can you come forward?
Okay. Sorry.
So what we want to do this time, hopefully, is to ask everyone, just like we did in the previous session, to reflect on the approach to research and the capacity strengthening that we conducted in this program, and just reflect on it. What are your personal reflections and thoughts on them? Would you want additional capacity strengthening in these areas? Is there a need for any? And then how can this approach be strengthened in future program design? So I think we'll probably just begin with reflections on whether you want to reflect on the approach to research or the capacity strength, personal reflection. Then after that, the second round we'll just talk about any how we can strengthen any of these approaches in the future program design. All right, so Jonas, sorry, you're going to start the reflection. Let's do it. Did you get what I said? Yeah.
On the other side of the project team member, the project has allowed us to build capacity in crucial areas of research and project management, skills that will benefit us for years to come. And when we look at our project implementation, we started with baseline survey, which this one helped us to tackle the gaps existing in the maternal healthcare services. So we prioritized those, we analyzed the data and we prioritized the area which we saw there's a need for improvement. One of the areas we started by improvement of infrastructure, like what my colleague Dr. Kalambula said, that we improved the area of NCMPNC by those, all of the equipment needed to improve that quality in NCMPNC. But the second one is we build capacity not only for our PhD students, but to the healthcare workers. So we provide them with a blended learning program, online and in person, so that to ensure that they are fully equipped with the skills they needed. And this was complemented with ongoing mentorship, which will help us to maintain what we've already started in the project. So to conclude, the approach was transformative, and we believe that in continuing with this collaboration and support, we are confident that we can continue to build this achievement and make a lasting impact in improving healthcare outcomes. Thank you.
Thank you very much, Mama.
First of all, thank you for giving me this opportunity. I have to be involved in implementation of health-related profession, even though I'm not the one. But because I'm an administrator, I have to be part of it. So I'll respond these three questions related to my position as a top-level administrator of the university.
Yeah, sorry, GBC, at this point, can you just take the first part? We're going to go to the last two later. But you can include, you can take on your reflection as well as any additional thing you want to say. We'll talk about the future.
Okay, thank you very much. Actually, I've tried to translate the questions that in such a way that my responses will reflect all three questions.
Then go ahead. That's fine.
So I'll add from what Dr. Salma just contributed, that we are a very young university with very limited skill capacity, and as it has been mentioned that most of the, if not all, members who are involved in the implementation of this project, it is the first time to manage and implement the project of at this magnitude. So for us, actually, using the basic skills of research methodology and statistics that we have, to me was quite standard, well accepted, because as it has been mentioned before, that you have started with the preliminary survey so that you can identify the gap, but then how to tackle the existing gap in terms of giving the solution at the same time, planning for the data collection so that we can justify how we can resolve what you have just observed. That was okay for me. But then on the side of capacity strengthening in terms of research, we as a university have that responsibility to involve our staff into academic activity, and one of them is research. So it exposed our staff to the real world of research. They have fully participated themselves from day one to the final day. And of course, through that, they managed to acquire skills to practice and acquire skills of implementation of the research work. So we hope through experience that was obtained in the implementation of this project, now they'll be able to write even their own proposals for the research and be able to implement it in a very standard way. That is one. But second, that was what has been done. But then what needs to be improved was making a follow-up every step of the implementation of the project. And then I had two complaints during the implementation. One was the data management. That there were some difficulties in obtaining the intended data from the surveys. And because this data management involved the use of technology, so it was difficult for them to have a fully access of the data. And I hope some of the data are lost on the way. So then I think that we need to improve on this component next time when we design for the new program. That is number one. But then second, on the same point, I think the data were not could not be managed in a standard that it was desired because of the difference in technology between the northern and the southern, particularly on the technical side of the internet connectivity. So I suggest again that next time, whatever we plan, and that we plan to use this technology, then we better set up this technicality before we move on. So for that three key points, then I say thank you for being given this opportunity to contribute to this discussion. Thank you very much.
Thank you very much. Can we have the last reflection by Zainab?
Okay, thank you. Good morning.
Good morning.
I don't know how can I say because Maria has taken all the notes. Because we are running in the same way. As a PhD student, my reflection is very highly positive because since I'm being a beneficiary of this project, I'm not working with the project, but I'm beneficial from this project. So it's helped me to build a capacity as myself. Yeah, really, I was not, I'm not an anti-head, but it was very difficult to understand how to conduct a systematic review, how can engage with the PhD work and everything. But finally, now I'm very much appreciated because now I know how to conduct systematic review. I know how can I collect data in a triangulation format, in different, in qualitative and quantitative. Even in qualitative, I was running away when I say that when I see the studies including qualitative, but now I'm very much appreciated and I'm ready to do a qualitative study because now I see I'm very much on building capacity on doing this qualitative study. So it was very nice because I got a chance to sharing a lot of information with the different expertise from LSTM, from project team, and from many angles. So, and also because during that implementation, I was involved in the training and different activities. So much appreciated and well capacitated in doing a mentorship, in doing how can we do implement a QI. So I was one among of the master trainers. So now I'm very well in training to others. So I can say in my reflection, I can say again, it was very positive, and I thanks again my university to allow me to join this PhD. And also I can thank all funders and all contributing in this PhD work. Most appreciated to my university. At LSE Liverpool School of Tropical Medicine, it's happened to be able to be more capacitated. So thank you very much.
Thank you. Can we just give a round of applause? It's very interesting to see the themes that have emerged from this first round of just trying to reflect on the approach to research and capacity strengthening. And I really liked the part where you tried to say, from the beginning, to guide our minds, in terms of the different groups of people that have benefited from the capacity building. So from those who are implementing from government side, to the students who are sitting here, to the actual healthcare workers that we are targeting. So it's not just about building the capacity of healthcare workers, but it's about influencing the entire continuum of the health system. So that's something that has come out really very strongly in this first round. And some are also using the term transformative. I'm really glad that we had to come to Zanzibar, and good to hear that this is the first time of its kind, and it's achieving this sort of thing across the different levels, from the health system to the university. Good to hear from the DBC about the alignment to what we're doing with the university plan. So I think that all those have come really clearly, and the PhD students particularly emphasizing the new skills that they have acquired, not only for research, which is a very interesting thing about it. So you acquire the skills around your systematic review, methodology, and all that. But in addition, the management of research. So being able to coordinate what goes on in the field, and then now being able to work remotely with people in Kenya. So I think this is an amazing thing that has happened and rubbing off positively in the health system. So thanks for those rounds of reflection. And thanks, DVC, you went into the next phase, which is just thinking about what can be strengthened for future programs, what can we do better, what are the ideas for innovation that has also come from here as we are chatting. And I think he set the stage going by hinting on a very important part of something that we need to work on the challenge, which is data. The capture, the management, and everything about it, which is very key. So I'm going to start the second round of reflection before we pass it on to the rest of the group. And we're going to start from there. What can be strengthened for the sake of future? If we were to do this again, in what ways would you want to see things done differently, improved upon, or changed, or anything? So I'll also borrow Helen's approach by starting the other way. So Zainab, we're going to begin from you now. You mentioned all the ways in which you gained from the capacity strengthening and your research, and your being able to manage research, interacting with a larger group. So do you want to tell us briefly what you think could be done better or improved upon in terms of the future? Strengthened.
Thank you so much for giving me another opportunity to say that in here. Yes, what can I say here is I think this innovative is need to be continuous. Yeah, because through this capacity building, the healthcare workers via blended learning, it shows us or it gives us a time to see how the healthcare provider they change their behavior while they're caring the woman during antenatal and postnatal care. Because I have an example when I collected data, the healthcare provider they say before that we are doing our we observe the patient or client during antenatal care, without bearing in mind the issue of respective for maternity care. So now they are able to do, and they can also able to implement this respective maternity care. And nowadays, when you go to the clinic, you find you will see many changes when you get these services compared before this innovative be implemented in our countries. So for the future, I think it's better to have another PhD student, because if we are many, I think we will able to continue to strengthen this innovation that LSTM, Takeda, and Global Fund initiated that's innovative to us. So it could help us to to encourage others from different aspects, because as you see here in Zanzibar, just the only 10 facilities are included. But I think if we are many, and if we can get another chance to implement another project, it could be better to reach a larger scale of healthcare providers. And we believe from this, we could be able to sustain or to improve our quality of service. In the end, we could be able to reduce this burden of maternal and newborn death. Thank you so much.
Thank you very much. So please feel free that any of the panelists to add. There's a second question there that I thought that it would be the first, which is about additional capacity spending. So we highlighted all the areas of success, all the action, the additional areas, while you also reflect all the capacity spending.
Thank you very much. I would like to talk about the challenges we encountered during the implementation of this project, and that is the area where it needs more strengthening. It's a data management and handling, which has already been covered by DVC Act. But I would like to add one more things, like we need to have a common training in data analysis, which will strengthen our skills in the area, and it will ensure that we are better equipped and handle and interpret the data effectively. Thank you.
Yeah, thank you, Mr. Chair. I think I'd like to add one more thing on top of what has just been proposed. I was scrutinizing if the data collected, I know they've been partially analyzed and been used to write the implementation report. And I was asking myself, have you gone to a step of writing the publication manuscript? I think, I'm not sure, but I think not. So I would suggest that maybe if possible, the way forward from what we have just got from the field, we can organize a session, a special session somewhere, where you could have a manuscript writing workshop, maybe a 7-day session, and then implementers from all countries can meet together, and by the end of the 7 days, they have their 2 from each group manuscript already written. I think that could be a best option to have the results of what we have been observing documented officially. Thank you.
Thank you again, Dr. Uzo. I think I'll start with how can this approach be strengthened. I believe, first and foremost, that the structure of the project was strong, and it was a good one because it has been successful in implementing most of the activities of the project. On the part of Tanzania, I think having the advisory board and involving the Ministry of Health and the PRAG and the regional
and district levels of health has been very helpful. And I think if learning from this, it is important to really make sure that they have a feeling of ownership, especially the regional and district level of health of the project. And that will really help in the implementation, but also in the sustainability of the project and the project activities and the innovations that have come up out of the project implementation. I think that Professor Charles having an LSTM team or LSTM branch as you have in Kenya and Nigeria wouldn't be a bad idea. You already have the team, you just need to officialize it. Yes, so I completely agree with Zainab that I would really love to see somebody else experience what I've experienced and be able to share the ripple effect, not being the only source, but also have multiple sources of the ripple effect with other academicians or other healthcare workers that can share in the PhD experience and be able to share more what we have. But I think it is important to note that had we involved, gone beyond the healthcare facilities to the community level, we would be having stronger effect on the community. So maybe to strengthen the approach would be having more community engagement and having aspects of creating awareness of the project and the activities in the community. Thank you.
Thank you, Chairperson. But again, I think Maria is pushing for an LSTM branch in Dodoma. But let me thank the regional medical officer. He's not here, but he's new in Dodoma. The regional medical officer whom you have seen here is new in Dodoma. And when he was invited in this meeting, he took an initiative to learn about the project. And he asked us to visit one of the facilities that has benefited from the project. At first, we thought we can explain to him about the project and then was enough. But he said, no, I want to hear first-hand information from those who have benefited from the project. It was so tedious, and it was over the weekend, and we had to comply because it's your boss. And then he said, no, it is still not enough. I need you to present to me the results, and the KPIs, and everything, etc., etc. I'm not getting tired even over the Sunday. Please come to my office and do that. Then we accepted. Unfortunately or unfortunately, then when we visited that facility, he got information that impressed him, and he said, no, I've got some information that I think give me an opportunity to say something. We'll discuss in Zanzibar. You will present to me. I think you saw us when we arrived on that day. We had a very long meeting with the RMO and the DVC academics. What happened now in that discussion? We discovered there were some gaps that we maybe, in case we advise how to strengthen the project. We discovered that we need capacity strengthening to these managerial positions. Those who are in managerial positions so that they can supervise, and again they know what is exactly going on, and they can manage actually the results that have been obtained. The ministry, the regional health management teams, the council health management team. We have one good example, I think. When we were doing the supportive supervision, we trained one of the district nursing officer. She has been involved. She is coming from Bahi. Now she is planning to adopt the methodology in the whole district. And the way she is supervising according to this model. So there is a need of strengthening the capacity of these managers. Whenever we plan, maybe to have another project or anything, so we don't forget. I was telling Mwajuma, I'm happy to see Nafisat in Liverpool, in Nairobi, and even here. And I know Nafisat is more competent in this project and she can say anything about this project. But again, what happened that we feel we can strengthen is we have invested much on the demand side, on the supply side. We have capacitated these healthcare workers. That is the supply side. But we have not capacitated, we have not created demand, the demand side. Maria have touched a little bit. If these women, when we were asking ourselves, the data have shown us that booking have increased. Then we asked ourselves, why booking has increased? While these women are coming while they are already pregnant. These women are coming to the facility while they are 3 months, 4 months, etc. Who sensitized them to come early? Again, the woman that is receiving service, again, you may see her maybe after 2 years or 3 years. So the demand side, if we can work to the demand side and the community, and then create this kind of awareness so that they can demand, they can push for service. This may help us. I think these are the 2 areas that I feel we can strengthen in case we have an opportunity to strengthen.
Thank you very much. Please, can we have another round of applause for our panelists? So you will agree with me that we've had rich discussions already. And what is coming through as we transit from reflecting on our successes and what we've learned around capacity strengthening and project management in terms of what we want to do in the future is very strong emphasis on data, which remains that big problem or challenge, let me not call it a problem, that every health system has to deal with, especially in the low and middle income countries. So we've heard a lot about building capacity in that area, whether it is training in data management or data collection, or even organizing beyond that to people being able to write up, maybe organizing something around manuscript writing. And it's a very, listening to the PhD students wanting to see more PhDs in these areas, and I dare to extend that to see more capacity building in that area. I agree that we need PhDs, but I also agree that a lot of the good work or a lot of the very impactful work being done are being done by people who do not have PhDs. So it's good that we invest in PhDs as well as in people in other kind of soft skills that has come through here that people can get. I've also underlined something around ownership that you mentioned, because it links somehow to sustainability, not some really links to sustainability. It was mentioned in the previous channel. And I've got a question there, so maybe we're going to reflect on it. How can we, as an implementation team, who are not necessarily all involved directly with government or with those that can make the difference, how can we help with fostering ownership? Then we talked about involving community level. Again, I talked very passionately about that. I don't know whether I was angry or so. So if I came across as angry, please forgive me when I'm talking about community health workers not being paid and being absorbed. So it's surfacing again that on the one hand, we are building capacity in the health system, among the workers, everyone, but then how about the real grassroots people that are doing the job? And then Leonard, you mentioned really important thing, which is some more focus on those who govern the health system, which is so powerful. in terms of capacity strengthening to those managerial positions, and then thinking about investing in creation demand. I forgot that I'm supposed to be a panelist as well. So if you don't mind, just 2 minutes for me to a quick reflection on what I thought, and then we throw it open for the rest of you. So when when it comes to reflecting on the approach to research and capacity strengthening, because I'm part of the team from Liverpool, being part of all the data collection, the M&E specifically is my task. And so I'm seeing all the issues that have been mentioned firsthand, and I really am sad that Chris isn't here. We have discussed all that. But in terms of reflection, I thought that there are very robust things that we did from the conceptualization of the research. We made sure that it was broad-based, it was driven by the needs of the population. We didn't hang it in the air, which is very good. And the focus has always been on areas of greatest need. I'm happy to see my country of origin, Nigeria, being part of this, because I reviewed the WHO maternal mortality data for 35 years that showed that our maternal mortality rate has not really changed over that period of time, even though loads of investments have been made and might have changed in places or overall from the estimates. So we are focusing on the areas of greatest need, and we've used a study design that included capture of qualitative information, because most times we just find ourselves lost in counting numbers. 1,000 women have died, 200 have died, 2% coming from maternity. But how about why is happening? So to ask those questions, get perspectives of healthcare workers and different stakeholders has been a very important strength of what we've done. You talked about learning new skills. So people like Maria and Zainab were, what we call participant researchers. So you are researching or you're participating. You're somehow, one of the participants because you are undergoing training. We are collecting your data. At the same time, you're a trainer and you're learning new skills. So that's an important thing. When we get people who are part of the system, someone like Salman, who is part of the system as a dean of the college, being part of the research team. So we have that first-hand information of what the issues are, like DBC says. We are part of the process of generating the data. You are there when the gaps are being exposed, and then at the same time, you're able to relate to policymakers. This is a very strong thing that we've done, and probably speaks to the issue of increasing ownership, and then getting involved in policy pathway and making sure that what we do is cost-effective for the health systems. So thank you all for really excellent reflections. And I'm going to throw the door open. I think I looked at the time and saw that we have generous amount of time, so I tried to finish everything I have here. But please now, the floor is open for comments and questions.